Hello and welcome to Vera Voices. I'm David Cloud with the Substance Use and Mental Health Program, and I'm here with Steve Rosenberg, President and founder of Community-Oriented Correctional Health Services. COCHS is a premier nonprofit organization that works to strengthen relationships between community health and criminal justice systems in order to address health inequities and also to improve public safety. Steve is also an expert on the implications of the Affordable Care Act for criminal justice systems. So Steve, I'd like to start with a general question. Tell us how the Affordable Care Act affects criminal justice populations.
Well, David, what do we know about the criminal justice population? We know that many of them are there because of untreated behavioral health disorders. 90% of folks leave jail without health insurance. A study done in Hampton County, Massachusetts showed that 80% of individuals had chronic medical conditions that had not been treated prior to their entering jail. So you have this large population that's circling in and out of our nation's jails because of untreated behavioral health disorders, and they're uninsured. So what the Affordable Care Act does is it creates an opportunity for insurance, which in turn has an opportunity to change how we think about this interplay between behavioral health disorders and the criminal justice system.
And what other evidence do we have that increasing the rates of insurance coverage as well as access to treatment will in fact benefit public safety and public health?
So the state of Washington has a very unique data set. Their data combines jail booking data, Medicaid claims data, and mental health and substance use utilization data. And in 2003, the state provided out of their general funds $30 million to enhance substance use treatment. And they then looked at what happened with the treated population versus untreated. And the results were startling. For every dollar that the state spent in substance use treatment, they saved $1.16 in hard criminal justice costs. The arrest rates went down by a third. If you count victims of crime, almost $3 was saved for every dollar of spending. But perhaps equally importantly, the healthcare cost curve changed. So in 2003 to 2004, for those individuals with SUD, their healthcare costs were increasing at a rate of 5.5% per year. Suddenly, between 2004 and 2009, the aggregate healthcare spending for this population went down by 2.2%.
And so how can local jurisdictions start to leverage the opportunities that the Affordable Care Act offers them?
The trick is going to be to enroll this population. In Massachusetts, in the aggregate, we have a 3% uninsurance rate. But a study showed among substance use disorder individuals who were admitted to publicly funded treatment, which is in effect the jail population, young, non-white, male, those individuals had a 22% uninsurance rate, because this is not a population that's going to knock at their welfare office with a kid with an earache and say, please enroll me in Medicaid if I'm in an expansion state. So the here and now challenge is all about enrollment, and how do you build systems within your jail? How do you build relationships to enable you to enroll individuals?
What other challenges will jurisdictions face as they try to implement the ACA in their jail systems?
Right now, criminal justice are thinking about themselves within a silo. And within that silo, they have their own sets of relationships. So they have their own community-based providers that they currently refer to. Those providers may not be Medicaid certified. They may have drug courts where you have judges that are in effect ordering treatment. And typically, insurance plans may have a benefit exclusion for court-ordered treatment. So criminal justice folks are going to have to rethink how their existing systems operate in light of the Affordable Care Act.
Can I ask you how these opportunities might play out in states that have opted not to expand Medicaid?
So I think in states that have opted not to expand Medicaid, the primary driver is going to be money. So since 1997, there has been the ability of states to not pay with their own general fund dollars when an offender is in a community hospital for greater than 24 hours. Typically, this has been an unknown and hidden piece of our Medicaid rule set. And so I think what you're going to see in the non-expansion states is you're going to see an effort to enroll folks for Medicaid to pay for that hospitalization when they're out of incarceration for more than 24 hours. But I think in many states, the Department of Corrections is realizing the relationship between recidivism and behavioral health disorders. So I think the question will be in a non-expansion state, do I keep funding this with state dollars, or do I think about Medicaid expansion as a way to lower my overall general fund cost?
We have expansion states, we have non-expansion states, then we kind of have a couple of states that are kind of in the middle of that spectrum. Does it play out any differently there?
No, because those states are functionally expansion states. We're still going to have coverage. The difference will be they'll be purchasing their coverage through the exchange as opposed to having a separate Medicaid problem. But because parity That is the requirement that mental health and substance use benefits parallel the benefits for health care. We're not likely to see a difference in those states.
So another key component of the Affordable Care Act and kind of its sister legislation, the High-Tech Act, seems to be a focus on health information technology. Can you please talk about how jails might think about investing in electronic health records?
Health information technology allows for full connectivity. So when that individual enters the jail, with a click of a button, I can go ahead and access their whole health history.
So it greatly improves the communication with other agencies as well as providers not necessarily located in the jail.
Absolutely. In jails, we stabilize the health of individuals that are under our custody because of their Eighth Amendment rights. The minute they leave the jail, we tend to lose that investment. Electronic health records allow us to maintain that investment by documenting what happened to stabilize their health and what was successful once those individuals leave corrections.
So it really gives us a chance to improve continuity of care. But aside from that, it creates a bunch of data. So what can government agencies, how can they use that data to their advantage in terms of planning, evaluation, and things like that?
We have information we've never had before. All of a sudden, we get to look at what is the clinical profile of these folks in jail. What are their pharmacy needs? What are their healthcare needs? What kind of tests do they need? So we get an epidemiological perspective.
We know, Steve, that health disparities in our jail systems are rife, and we also recognize that a big piece of the Affordable Care Act is a commitment to abating health disparities. Can you just speak to how we might think about achieving that mission with the jail population?
We have disparities in our health system that are self-evident, that are again due to a lack of insurance. We have disparities in our criminal justice system. As I said previously, those are generally driven by a lack of insurance in the community. So the question becomes, once we create coverage, once we create an entitlement to health care, will that let us rectify the disparities in the community? And in doing that, will we have an opportunity to rectify the disparities in the criminal justice system?
Thank you very much for being here today, Steve. We really appreciate you taking the time to talk to us about such an important topic.
Thanks, David, and thanks for the opportunity.